oh, here we go. This is being recorded. Okay, fine. So yeah, I'm going to give you a bit of a roundup of the pharmacy station at OSCE. I know for some people it's a complete write-off, and then other people seem to do really well. So hopefully after today's session, you'll feel a bit more confident with prescribing. So we're going to revise the key principles of prescribing. So I'll just be taking you through the prescription sheet. And then we'll look at the 5 key areas that they test in prescribing. So these are anticoagulants, antibiotics, insulin management, and especially hypoglycemia that comes up often in your OSCE. IV fluids, I know people have a lot of trouble with IV fluids sometimes, I'll be going over those. And then controlled drugs and like pain meds and things, because palliative care is obviously interwoven in the OSCE stations. So throughout, I'll just refer to some typical scenarios that you'll get in your OSCE, but I'll just try and get through it as quick as I can, because at the end of, if you've got any questions or you've got any specific things that you want to talk about, just tell me and I can like talk you through it, and we can do that kind of thing, because I think that works best instead of me just boring is all, essentially. Okay, so this is the prescription chart that you'll get in your OSCE, the front of it, and one of the most important things is to make sure you get all this information on your prescription sheet like filled out. There's so many marks.
Where are we going? I'll just get outside or inside?
Yeah, outside.
Yeah, so make sure you fill out all the important like particulars information. So when they were admitted, what ward they're on. I think the most important things is their height, weight and allergies. So as long as you get those and the sticky label for their like hospital number, that's the main things, but try and fill everything out at the top of that form. You can ignore that, that's for nursing staff, it's not for you guys. And then immediately below that, you've got your once only prescriptions. So they're for like your stat prescriptions essentially. So if you've started someone on empirical therapy for their UTI, the cultures come back and they're actually resistant to that, and you want to start them on amoxicillin or whatever, you could give them a stat dose there and also prescribe it on your regular medications as well. So that's where you do your stat prescriptions. Then you have the oral anticoagulant prescription chart underneath that. So this is where you prescribe warfarin. And the thing with warfarin is you literally have to fill out all these boxes apart from a couple. So just start from the top. So if it's atrial fibrillation, for example, it's going to be lifelong. And I always find that like write in block capitals, even if it's not, even if you're not used to it, because it's like the clearest way to write your prescription. So along the top, you need to have the duration of their treatment. So if they've got atrial fibrillation, that's for stroke prevention, it's lifelong. Their usual maintenance dose might be 3, 4, 5, 6, whatever milligrams. It'll be given to you on the sheet. And the target INR is 2.5. And then if they give you their usual therapeutic range, you should like bracket that out too. Obviously you need your date. What's today's date? The 17th. The time. And then the medicine. And then the usual dose is 4 milligrams and it's prescribed by yourself, so sign it. And then if you've got their latest INR, you can record that on the chart by just placing an X on there. If it's 2.3, it would be like over the line because it goes up in 2s. But you don't need to fill out this bit. And then you also need to make sure you prescribe it on the regular medications, which is the next bit, if this wants to turn. There we go. So you'd also have to prescribe warfarin on this chart as well. And in where it says dose, you just write C chart, but we'll go over anticoagulants in a minute. I just wanted to show you that anticoagulant chart on the front. Okay, So as required prescriptions are your PRNs. So it's usually your salbutamol inhalers or other inhalers, your paracetamol and things like that. And I'll show you some examples of those later. And then on the back, you'll have your IV fluids. So we'll go over IV fluid prescribing. So maintenance and resuscitation fluids. We're not going to cover replacement fluids because you won't be asked to do that because it's quite complicated. Okay, so anticoagulants, there's 3 key classes. You've got the coumarins, which include warfarin, DOACS, so that's your factor 10A or thrombin inhibitors. And then you've got your heparins, so your unfractionated or low molecular weight heparins. And in your OSCE, there'll be 5 like typical scenarios. So AF, if they've got valves, mechanical valves, PE, DVT, and then prophylaxis. So warfarin, let's do the first one. It's not as commonly prescribed in new patients now, but you will see it a lot on the wards. And as an F1, you know, it's kind of the bane of your life. But it's a vitamin K dependent clotting factor. It does take up to 3 days to take full effect. So sometimes you have to bridge patients with heparin and things like that whilst they're getting that full anticoagulant effect. As I mentioned before, you prescribe it on the front in the anticoagulant chart and in the regular meds. And if you want any information on warfarin during your OSCE or anything like that, navigate, you'll have the BNF on an iPad in front of you. And if you just go to treatment summaries and then oral anticoagulants, and it's literally has everything there. They might give you a scenario about bleeding, which is why I've got that huge table there, which I'll talk you through. But generally, you reverse warfarin with vitamin K, and that's under phytomenadione on the BNF, confusingly. If you search vitamin K, it might not come up. And then you restart your warfarin when it's the INRs less than 5. So with bleeding, it's categorized into no bleeding, minor bleeding, and major bleeding. So if the INR's raised and there's no bleeding, you just withhold 1 or 2 doses if it's between 5 and 8. If it's greater than 8, you need to stop the warfarin completely and give them oral vitamin K. If there's any bleeding, the vitamin K you need to give has to be IV. So look out for that. And you have to stop warfarin, obviously, if they're bleeding. A minor bleeding would be things like a small nosebleed or a cut that's not stopping. Major bleeding, we're talking like hosing out of somewhere, major hemorrhage protocol kind of thing. And that's why you would give these other drugs in combination with IV vitamin K, like the prothrombin complex and FFP, although that's less effective. So yeah, that table can be quite handy. When reviewing warfarin, I'll do questions at the end, otherwise I'll just be stopping and starting, but yeah, I'll definitely come back to that. When reviewing the warfarin, so say if it's low, the INR is 1.5, but it needs to be 2, you need to work out what their total weekly dose is and increase it by 10% and then split that back over the week. So if it's 30 milligrams they have in a week, you need to increase it to 33 and then divide that by 7 and work it out with like 3, 4, 2 milligram tablets and stuff like that until it adds up to 33, sorry. If the INR is too high, that's when you hold doses and things. Yeah, I can repeat it. So when you're reviewing warfarin, if the INR is too low, so it's 1.5, but it needs to be 2 or 2.5, you calculate their total weekly dose of warfarin. So if they have 3 milligrams on a Monday, 4 milligrams on Tuesday, 4 milligrams on Wednesday, 3 on Thursday, you just add it all up, increase it by 10%. So if it adds up to 30, increase it to 33, and then split that back over the week. So you just go backwards. So you might have 3 milligrams on Monday, 4 Tuesday, Wednesday, Thursday, Friday, 3 on the Saturday, 3, you know, whatever it takes to add up to 33 essentially. That's how you review the warfarin. Yeah, is that okay? Yeah, great, perfect. So DOACS, so these are your things like apixaban, rivaroxaban, edoxaban, and dabigatran. So they all have that handy XA in which tells you they're an XA inhibitor apart from dabigatran, and that's because that's a thrombin inhibitor. The good thing about these medications is that they don't require any monitoring, and they're indicated mainly for these 3 things. So stroke prevention in AF, and it has to be non-valvular AF. For example, rivaroxaban isn't licensed for patients who've got mechanical valves, but I don't think they'll go to that level of complexity in your exam. It'll just be someone's got AF and they need stroke prevention, prescribe something. And it's also indicated if the in DVT and PE if it's confirmed. So check in your scenarios whether they're still under investigation or they've had the Doppler or the CTPA or VQ scan, because it's not licensed until it's confirmed. So in that case, you'd use low molecular weight heparin. You also use low molecular weight heparin if they're pregnant or if they've got active malignancy. So you wouldn't use any of these DOACs in those situations. They can also be used for VT prophylaxis, so post op and after, post op for knee and hip operations. But as I said, the best place to find these, if you go to treatment summaries and then venous thromboembolism at the bottom, and it'll tell you all about prescribing in surgical patients. So for pre-op warfarin, this is one of the questions, they need to be off the warfarin for at least 5 days. And then after warfarin, you have to bridge the warfarin with a heparin because it does take that 72 hours. So you'd bridge with heparin until the INR is at least 2, and then you can just keep them on the warfarin. So that's what you do post and pre-op. Just to answer that question. Yeah, so BNF treatment summaries, venous thromboembolism in your exam. So low molecular weight heparin, it's a subcutaneous injection, and it's, you guys have obviously been on the wards your 4th years, but it's usually given at 6 p.m. They're the 3 main drugs in and around Liverpool, really. Pick one and learn how to prescribe one, and then you don't have to remember the others. So I use dalteparin. I find it easier. So prophylaxis in medical patients is 5,000 units. Treatment dose is between 7,500 and 18,000 units, depending on weight. For most people, it'll be 15,000 units. So that's easy to remember then. 5,000 prophylaxis, 15,000 treatment. So that's why I just picked dalteparin. Surgical patients are more higher risk than medical patients. So just check the BNF for the prescribing for those, because it depends how close they are to the operation, and after their operation, what dose you give for VT prophylaxis. So just check the BNF for any surgical patients. But if you pick dalteparin, prophylaxis is 5,000 units for medical patients and treatment 15,000 units. But if the weight, if they're overweight or underweight, it'll be to that range of 7,500 to 18,000 units. Okay. And enoxaparin is the only one that's prescribed in milligrams. I don't know why really, but it is. And it's usually a 1 milligram per kilogram dosing in treatment, and then in prophylaxis it's 20 milligrams for medical and 40 for surgical, I think, but don't quote me on that. Yeah, so that's the same treatment summary. So I've done a couple of prescriptions, like how I would write it out. So we've all seen this one from the front. So the duration of treatment, the indication, the dose, the INR range, label INR as appropriate, and then your actual prescription. So the date, the time, the medication, the dose, and your signature. And that's all that requires. And then you would write that, so C chart, and always include an indication for any prescribed, like it's just easy to write in and it completes your prescription essentially. So atrial fibrillation, and just make sure you sign it and date it. Some people like writing once daily, twice daily, QDS, all that kind of stuff on the left-hand side. But if you've put the times in underneath date and time, you don't need to write that. But you can if you want. So I've written a treatment as well. So you'll get a copy of these slides. So you've got like a reference for how you would treat a PE. So this person, you know, had features of a pulmonary embolism. They were still under investigation, so they couldn't go straight onto a DOAC. So you have to give a low molecular weight heparin for 5 days, and then you treat with the edoxaban after. So like I said before, the treatment dose of your heparin would be 15,000 units for a 67 kilogram male. It's a subcutaneous injection. I've written the indication there. You have to put a stop date on this because you're only giving it for 5 days. So you can write 5 days, or you can put the date that you want it to stop on. It doesn't really matter which. Obviously you need your signature and the date you want it to start. And a really good thing to do in your exam, because it shows the examiner that you really know what you're doing, is to put squares around the 5 days and block out all the rest, so no one can inadvertently prescribe outside of that. And then for your edoxaban, it's the same. Write your name of your drug. I use block capitals because then it's not ambiguous. Your dose, your route. So this is oral instead of subcutaneous. Your indication, your signature. And then block out the first 5 days, and then use the squares for the rest. At the top with the dates, you do have to write each individual date out, like 6th, 7th, 8th, 9th, 10th. I've just done the arrow because I'm lazy. So just be aware of that. You know, it's dead easy when you're in a rush and you're stressed to forget to actually write the date at the top. But that's marks. You know, you get in OSCEs, you get marks for like the basics. So it's important to get that done right, and then you'll score really well. So there's those examples of prescriptions. So I'm going to move on to antibiotics. So you should always start smart and then focus. So use empirical antibiotics first, and then when your culture sensitivities come back, you narrow the spectrum. So the likely scenarios you get, I mean, gentamicin would be harsh, but because there's a lot of iatrogenic harm from gentamicin prescribing, it could come up. But usually it'll be a urinary tract infection, a pneumonia, or a hospital-acquired pneumonia. I think we've had UTI a few times, and we've had CAP and HAP in our FOSCEs. So you'll be given like a set of vital signs, a brief history, a chest x-ray or a urine MSU, depending what scenario it is, and you'll be asked to prescribe the regular medications and the antibiotic treatment for the therapy. And this is why when you prescribe regular medications, it's good to know some interactions with your antibiotics. So for example, clarithromycin and erythromycin you use in pneumonia prescribing. So clarithromycin if it's severe, and erythromycin if they're pregnant. But it can interact with a whole host of drugs, and we'll go through inhibitors and inducers later. But it's, you know, there's some medications you might need to hold on your prescription chart or completely stop, depending on the antibiotics you're prescribing. So for a UTI, if you go to BNF treatment, some reason urinary tract infection, that will give you all the information you need on UTI. It literally separates it out for lower urinary tract, pyelonephritis, complicated, uncomplicated, what do you do if they're pregnant? So it's all there for you. Half the battle is just knowing where to look and knowing where to go. So a note on pregnancy actually is do not use trimethoprim in the first trimester or nitrofurantoin in the third. It's okay to use nitro in the first and trimethoprim in the third, but obviously trimethoprim reduces the amount of folate, and you don't want to do that in someone who's pregnant in the first trimester anyway. And nitro has been shown to cause cardiac abnormalities, congenital abnormalities, something like that, in the third trimester, something like that. It's all in the BNF. So empirical treatment for UTI is either nitrofurantoin or trimethoprim. Another way that they try to catch you out is the renal function will be off in the patient. So if their EGFR is less than 45, you can't give nitrofurantoin. So just look to see if there's a UNE in any UTI prescribing. You can give trimethoprim, but if it's really bad, so between 15 and 30, they might ask you to half the dose after 3 days. So if it's a longer course, or if it's less than 15, so really knackered kidneys, just half the dose for the whole course of it. And complicated UTIs, you give 7 days of treatment versus 3. So all men are complicated. Any instrumental stuff that they have had recently, things like that. But it gives you a list in the BNF of things that are included there. And be guided by the cultures. Remember to check the patient allergies. In the exam, there's usually 2 drugs that are sensitive. So I remember we had like amoxicillin and cefalexin, but they were allergic to amoxicillin. So you had to prescribe the cefalexin. So just be aware of that. And again, like look at their renal function. It's dead easy to just search the drug and click renal impairment on top of the monograph. And it will tell you if you can prescribe it in renal impairment. So like pneumonia, so that's under, which, you know, would be nice if it was under pneumonia or CAP or whatever, but it's under respiratory system infections, antibacterial therapy, which is nice of the BNF to make it simple. So if it's a CAP, you should use curb score. So I'm sure you all know what that is. So if you've got someone with a curb score of like 3, you know, that's a high severity infection, and therefore you should treat with intravenous antibiotics, and it tells you what to use first line there. If it's moderate, it's amoxicillin, and low, it's amoxicillin as well. But you're more likely to use IV preparations for moderate severity pneumonias, whereas if it's low severity, it can be managed in the community, really. So it's using your curve 65 score, determine what the severity is, and then prescribe what the BNF says. If they've got a penicillin allergy, it says it right there, use clarithromycin or doxycycline. I always favor doxycycline because it's got less interactions and it just saves the hassle of having to hold other drugs on their regular meds. So usually you'll see they'll be on a statin or something, warfarin or whatever. So you don't really want to prescribe clarithromycin. I would prescribe doxycycline over it. Okay, and then for HAP, let me just get this to go back. Come on. Oops. There we go. So for HAP, the first line is comoxiclav straight away, or doxycycline. And then if it all, as opposed to curve 65, it just depends how unwell they are in hospital. So if they've got features of sepsis and things like that, you would prescribe the tazocin, which is like the Domestos, isn't it, that everyone uses. In our FOSCE, it was a CAP, but then they recovered and then they came back in or something, and then it was a HAP, and it was all very weird. It was a very weird station, but FOSCEs are weird. Your real exams will be obviously tested better. Okay, so I'm going to go through gentamicin. I don't think this will come up, but I think it's good to be aware of it. It's usually given in once daily or multiple daily dose regimens. I know the trust that I'm at, Whiston, they just use once daily. and the dosing for that is 5 to 7 milligrams a kilogram. And then you do trough levels to work out a serum gentamicin concentration, and then that dictates when you give the next dose. So for weight, you should really use ideal body weight, especially if they're overweight. If they're underweight, it doesn't matter to do the calculation, you just use their actual body weight, because they're more likely to suffer from kidney problems and stuff. So you use their actual weight instead of their ideal weight. But if they're overweight, you would use ideal body weight. The calculation for this is in the BNF, and it is on the gentamicin prescribing, I think. Yeah. Also, gentamicin is oto and nephrotoxic. So if their renal function is, if they've got AKI or something, you definitely want to hold this drug and switch it out for an alternative. You'd usually just stop it, really. Come on. There we go. And then you'll become familiar with this as well. So this is the graph which shows how your dosing should be for gentamicin. So you can't take the blood test until at least 6 hours, because that's when the graph starts. So once you give their first dose of gentamicin, you have to wait at least 6 hours before you take a level. And then, so say if at 8 hours, your gentamicin level was 8, which would put you in the 36-hour bracket there, you wouldn't prescribe the next dose until 36 hours. If it was 4, you would prescribe the next dose for 24 hours from their infusion. Yeah, so if it was 4, you just prescribe the next day. If it was 8, you prescribe a day and a half, and so on. If it's above 48 hours, you would just hold it until it goes down to 6, really. Okay. So antibiotic prescribing. So I've done a couple of prescriptions here. So the first one is for levofloxacin. So that's what you prescribe to someone with a penicillin allergy with a severe CAP. So I've written the drug name. The dose is 500 milligrams. It's given IV. You have to write the indication. For any antibiotic, there has to be an indication. You'll lose marks if you don't put it. So write the indication, CURB-3 CAP. For levofloxacin, there's a specific requirement to give it over at least 60 minutes. For the other ones, I don't think there is for like comoxiclav or tazocin or anything like that. But the way you would find a good way to check for that, if you don't know, is search the drug on the BNF and then click medicine administration, and it will tell you there. It's given BD, so I've put 8 a.m. and 8 p.m. because that's 12 hours apart. You don't, it might be annoying. So acronyms are okay. So like I've written CAP. You can write UTI. You can write PE for PE, in the previous ones for pulmonary embolism. So, as long as it's a familiar acronym and it's not ambiguous, then it's fine. If you are worried, just write it out, but you don't need to. So yeah, so for B, you need to have a good 12-hour cover there and after. So you wouldn't put 8 a.m. and 4 p.m. for example, because that wouldn't give them enough cover going through the night with the antibiotic. So you want to spread them out evenly if you can, and obviously do your boxes and cross out. It's a 5-day course for levofloxacin minimum, but if you don't want to specify 5 days because you're unsure, you could just write review in 48 hours, because most IV medications will be reviewed at that point to see if you can switch to oral, and that would be a correct prescription. So that's fine, but make sure you got your start date and your signature as well. The same for like trimethoprim. It's a complicated UTI. give it for 7 days. I haven't done the boxes there because you don't need to do the boxes, so just do whatever you feel comfortable with, but I prefer the boxes. Yeah, and I've written that it's a complicated UTI because some people might see 7 days and be like, oh no, that's wrong, and only give it for 3. Where would you write review in 48 hours? So you can write that as a stop date, so RRV 48 hours, or you can literally just write it on the prescription itself. So review 48 hours. You can just write it there. As long as you make sure anything that you write on it has been signed by you, then that's okay. And if you want to stop prescriptions, so if you want to stop this levofloxacin, you need to scribble it out and write stopped. You can give a reason, you don't need to, so you might write stop due to deranged LFT, sign it, and then that's fine. But you have to make sure you cross through the whole prescription, not just this bit, cross through this as well. Okay. So moving on to insulin. You're unlikely to be asked to prescribe for a new type 1 diabetic or intensified treatment for a type 2 diabetic. So if they've been on metformin and now they need insulin, because it's very hard, you know, specialists are the one that decide like how many units you start on, like the specialist nurses and things. So you won't have to do that. Previous scenarios that always come up are like adjusting insulin. So you've been given a load of blood glucose levels. One of them's too high, one of them's too low. What do you do? Hyperglycemia comes up a lot, more than DKA. DKA will come up in your written exams, whereas hypoglycemia will come up in your OSCE. So if they are hyperglycemic in between doses, you just adjust the dose by 10% and you go for the one that's before the high level, if that makes sense. So I've got a little thing here at the bottom. So you can see there that the pre-dinner glucose level is a little bit high. So you would increase the lunch insulin prescription by 10%. So if it was 20 units, you'd increase it to 22 units of whatever insulin they have. If they're on, that's if they're on a basal bolus regime, so like one with every meal and a long acting overnight. If they're on like a biphasic one, so like in the morning and at night, you would change the morning one because that would fix the dinner one. The only time you need to change the bedtime one in the biphasic is if the morning levels are high. Otherwise, you would, for everything else after, you would just change the morning one. So it's the one before that you go for. Yeah, I can go over it. So the one before, so if they're pre-dinner, so they take their blood glucose level after their dinner, no, before their dinner, and it's 12.5, you would change the lunchtime insulin, if that makes sense, because that lunchtime insulin is the thing that's going to change the pre-dinner glucose level. If you change the dinner glucose level and increase that, it's not going to fix the problem that's happening between lunch and dinner. So you just go for the one before. That's if they're on basal bolus regime. If they're on, essentially you fix the one before the highest. That's the way that I've just learned it in my head because it's just easier to understand. And it will be like a basal bolus regime because they like to give you these 4 levels in like a type 1 diabetic or something. But if it is like type 2 diabetic who's on like intermediate acting twice a day or like a Nova mix or something, you're more likely than not going to be changing the morning dose. Yeah, perfect. Okay, so management of hyperglycemia, and I've written a prescription up for you as well, so you've got a reference of how to prescribe the glucose. So it's BNF treatment summaries hyperglycemia. It's quite easy to find, and it's grouped into unconscious and conscious. So if they're unconscious, the BNF says to give IM glucagon, and if no improvement after 10 minutes, move to IV glucose. In reality, you're going to be getting that cannula in, unless they already have one, and getting the glucose in quite quickly. But that's practical prescribing. This is OSCE prescribing. So you give IM glucagon. I mean, if they've got a cannula in already, you wouldn't bother with the IM glucagon. You would just go straight to giving glucose. And then you need to follow it up with a long-acting carbohydrate after. So it's usually 2 biscuits. So if they're unconscious, IM glucagon, every ward has the little packs, and it's just an injection into the thigh. Check their levels after 10 minutes. If there's an improvement, great. They should become unconscious, or conscious again, sorry. And if not, you need to move to IV glucose. And you want to give 15 to 20 grams of glucose. So glucose comes in different kinds of bags. So 20% bag, 10% bag, you can get 5% bags. You can get 50% bags, which are like syrup. A 20% bag is easy to remember. You just give 100 mils. 10% bag, 200 mils. And as I said, follow up with long-acting carbohydrate. If they're conscious, you start with 15 to 20 grams of quick carbs. So that can be something, or some like sugary sweets. It can be 200 mils of orange juice, Lucozade, whatever you've got. And you can repeat that 3 times every 10 minutes. But if there's no effect after 10 minutes, yeah, I've written that wrong. It's not repeat up to 3 times every 10 minutes. It's just repeat up to 3 times, measure the blood glucose. If it's not improved after 10 minutes, you need to move on to IM glucagon. And if there's no effect of that after a third of 10 minutes, you just give the glucose as above. So unconscious, glucagon, no response, IV glucose, they're better, long-acting carbohydrate. Conscious, you give a liquid glucose like orange juice, whatever. If no effect, you give glucagon, and then if no effect, you give glucose. So that's hypoglycemia, and this is the prescription you would write. So you've got the date, the time. We're using glucose 10%, so 200 mils would give 20 grams of glucose. There's no drug additives, and the infusion rate is 600 mils an hour, and that's because you have to prescribe it. Yes, I would. You have to prescribe it, or more frequently, actually. You would check the glucose a few minutes after you've administered whatever you're giving them, but at least every 10 minutes. So yeah, the infusion rate here is 600 mils an hour because you have to give the 200 mils over a maximum of 20 minutes, or around 20 minutes. So if you work that out per hour, so 200, there's 320 minutes in an hour. So 200 times by 3 is 600. So if your infusion rate 600 mils in an hour, you'll give 200 in 20 minutes. So just like practice writing out a glucose prescription that you're happy with, and gives the right amount of glucose over that time. As I said, you'll get these slides, so you could even just use that one if you wanted to. Okay, so IV fluids. This one's a bit meaty, sorry. Don't worry about colloids. There's no point, you'll not be tested on them. But BNF treatment summaries, fluids and electrolytes. For crystalloids, it mainly falls into 3 categories. So you have maintenance, replacement, and resuscitation. So for maintenance, you want to give 25 to 30 milliliters a kilogram a day of fluid. So for a 67 kilogram person, that's about 2,100 mils. And you want to give 1 millimole a kilogram a day of electrolytes, so your sodium and your potassium. And you have to round down. So if they weigh 67 kilograms, you round down to 60 millimoles. You don't round up to 70 millimoles. But that's all in the BNF under fluids and electrolytes. And you need to remember that your potassium maximum infusion rate is 10 millimole an hour. You can do higher in places like ITU and stuff, but they need cardiac monitoring and telemetry and things. So that's out of our remit. And then for glucose, it's 50 to 100 grams of glucose a day. So that's maintenance. And then resuscitation, just learn 0.9% sodium chloride, 500 mils or 250 mils if they've got heart failure or they're really old, over 15 minutes or less. And you can use up to 2 liters. So replacement, it's not going to be tested. It's quite complicated. You know, you need to add and subtract the losses and things from like the gut and like the esophagus and things like that. It's just far too like, it's usually the reg and things that will deal with things like that. You might be asked to prescribe as an F1 it, but you'll be told what to prescribe by the reg, so there's no point bothering with it really. So maintenance fluids explained, because this took me, yes, you would prescribe IM glucagon in a once only. Yeah, so maintenance explained, because I felt that like it took me forever just to get my head around to like how many millimoles are in this bag of fluid and stuff. How do you actually work it out? So that's your requirements that you need. So in a litre bag of 0.18% saline with 4% dextrose or glucose, depends what your trust has, and 40 millimoles of potassium added, so that would go in your drug additive section, would provide you with 30 millimoles of sodium, 40 grams of glucose, and 40 millimoles of potassium. This is all in that BNF fluid and electrolyte thing. So if you scroll down, it'll have that bag of fluid, 0.18 saline and 4%, I think it's glucose, but in the BNF, but it's the same essentially as dextrose prescribed, gives you the same amount. And it'll tell you how many millimoles of sodium and glucose you get in that bag. So for a 67 kilogram person, you get 60 millimoles of sodium. You require 60 millimoles of sodium, 50 to 100 grams of glucose, and 60 moles of K plus over a day. So that bag gets you on your way to that amount. But your next fluid bag would need to provide enough, would need to provide more sodium, more glucose, and a reduced amount of potassium, because you can't give them 80 millimoles in total. So you would give instead the same amount of saline, so 0.18%, because that'll make it 60 in total. The same amount of glucose, so that's 80 grams, so that's between 50 and 100, which is fine. But then you would add 20 millimoles of potassium as your additive, because then that would make 60 in total, and then that person's sorted for the day. I'll show you an example of this in a sec. Just a reminder that 0.8% sodium chloride that everyone seems to prescribe is 150 millimoles of sodium. So it's like a double overdose for this patient over that. So you shouldn't use it for routine maintenance. It's just used in like shock, resuscitation, like kind of situations. Although you do see some people like hanging a bag in A&E of 0.9% sodium chloride, but it is very salty. So below the glucose prescription, you can see our resuscitation prescription. So you've got your date and your time, your 500 mils of sodium chloride, 0.9%, and the rate of infusion is 2,000 milliliters an hour, because you want to get that fluid in less than 15 minutes. So at 2,000 mils an hour, you'll get 500 mils in 15 minutes, because that's a quarter of an hour, essentially. And then for maintenance, so for a 67 kilogram person, you need 2.1 liters. So if they're 80 kilograms, you just wouldn't use the 0.18% bag, you would use a 0.3% bag. Or you can give the fluid over, if they're 80 kilos, they need more fluid over the day. So you can give like a 500 ml bag over 4 hours, for example, or something to make it up. You've just got to do the maths, essentially, how you're going to split it over the day. So yeah, so going back to this, they've had a litre of the sodium chloride with dextrose, we've added 20 millimoles of potassium. And that's over 125 mils an hour. So that's an 8-hour bag. I think 75 mils an hour would be a 12-hour bag. You can't just write 12 hours, you have to write the milliliters per hour. And then if that's at 8 a.m. one, and that lasts 8 hours, you then need to give another one at 4 o'clock. And a 67 kilogram person needs about 2,000 mils, 2,100 mils. So that prescription would cover them for total fluid amount that they need in a 24-hour period. It gives them enough sodium chloride because there's 60 millimoles. It gives them 80 grams of glucose. So that's between 50 and 100. That's enough. And then we've got 40 millimoles added this time instead of 20. So that gives you 60 in total. So it is just working out and doing the maths, which can be annoying and took me forever to get my head around about all the millimoles, but hopefully you guys will be better than me. Okay, so controlled drugs, just because we are flying through time. So on the BNF, if you click medicines guidance and then prescribing in palliative care, that'll have all the information you need on opioids, things like midazolam, glycopyrronium, all your antiemetics and things that you would use in palliative care. But I think it's important to know the WHO analgesic ladder, just because we had a station in the OSCE where it was like, take a brief history, you found out she's struggling with pain, she's just got codeine, and then you're asked to work out what the treatment intensification is. So going from a weak opioid to a strong opioid, and then describing that to the patient and things like that. So know your WHO ladder. As I said, it wasn't a prescribing station itself, but I thought it was important to include it here because there will be a palliative station somewhere and it will revolve around some kind of symptom management, and it is usually pain. So your step one is like your paracetamol, ibuprofen, and your adjuvants are things like a TENS machine, acupuncture, things like amitriptyline and stuff like that. And then you step up to a weak opioid, which is things like codeine, and then strong opioids are like your morphine, your diamorphine, your oxycodone. I've just done a PRM prescription there, just because it's under pain medication. So you can see that I've prescribed paracetamol. You have to include an indication, and it's a tiny box underneath. So it's very easy to miss in the exam. So paracetamol, the indication is pain. The frequency is 6 hourly, so 4 times a day. You can give 500 to 1,000 milligrams. You can just put 1 gram if you want to. The route is oral, and this is probably the most important part of a PRM prescription, is putting the maximum dose in 24 hours. So for paracetamol, it's 4 grams. Otherwise, I could just keep eating away, chomping away at paracetamol. No one would even know. So you have to put that there, and then obviously your signature and your start date. And then the other boxes are filled out by the dispenser or the nurse, whoever's giving out the meds. So conversion, so this is all in the BNF under the palliative prescribing. So I've just put it there, but I'm not going to go through it because it is just there. You won't need to know it because you can just look it up. So a little scenario for you guys. So we have a 75-year-old woman who's admitted with intractable pain. She's got a past medical history of metastatic breast cancer. She's on MST 60 milligrams orally twice daily. She takes Oromorph 10 milligrams in 5 ml oral solution for breakthrough pain. And she takes 5 mils of that every 4 hours as needed. And so far, every day this week, she's taking it 6 times a day as the pain's really bad. Went one step ahead there. So what I want you guys to think about is, how are you going to increase this person's pain medication? So have a little think in your head. I'll just go through it, it'll be easier, won't it? So to work out how you increase morphine, you need to work out the total morphine daily requirement. So she's having 60 milligrams of MST twice a day, so that's 120 milligrams, and she's having 5 mils, which is 10 milligrams of Oromorph 6 times a day. So that's 60 milligrams. So the whole dose for the day is 180 milligrams. So if you've got MST continuous, which is BD dosing, so twice a day dosing, you then need to half the 180. So she gets 90 milligrams in the morning and 90 in the evening, which makes the 180. But then you also need to calculate her new breakthrough pain dose. Oh, yeah, just a note, don't increase the morphine by more than 50% of the background dose. So in this scenario, 50% of the background dose would be 30 milligrams. So we're at the top end of that level. If you increase it more than that, you can cause side effects, like, you know, more likely to cause side effects. They might become toxic with their pinpoint pupils and jerking of the limbs and stuff. So don't increase it by more than 50%. Usually in the exam, in the scenario will be so that you can't increase it by more than 50%, otherwise you've done it wrong. And then for breakthrough doses, it's a 1/6 or a 1/10 of the daily dose. So the range here would be 18 to 30 milligrams. 30 milligrams is quite high for like a breakthrough dose. So I'd probably pick 20, but it is like your discretion, or, you know, you can adjust it later if the patient requires. Okay, so usually they'd get you to do that and then be like, oh, convert this to a fentanyl patch for when she goes home. So again, you just go to the palliative prescribing in the BNF, scroll down to where the fentanyl patches are, and take the total daily morphine requirement. So here it's 180, and look what that conversion is to fentanyl patch, and it will tell you. So 180 milligrams of morphine is equivalent to 75 micrograms even, of fentanyl. So this is your breakthrough prescription. So you'd write it as morphine sulfate oral solution. You wouldn't write necessarily Oromorph because it comes in different strengths. Some people might not actually know what that is. So we haven't given the same dose as MST. Sorry, that should be this bottom bit when I've said 18 to 30 milligrams. I mean that in Oromorph, if that makes sense. So you would give, for 20 milligrams of Oromorph, you'd give 10 milliliters. Yeah, great. So this is that prescription for you here now. So morphine sulfate oral solution, 10 milligrams in 5 milliliters. Breakthrough pain is the indication, so don't forget to write that. The frequency is 4 hourly, and the dose is 20 milligrams that we're going to give. And then the max dose is 120 in the day. So there are 6 doses if it's given 4 hourly. So 6 times by 20 is 120, if my maths is right, yeah. So that's just your max dose. And then obviously you need your signature. Sorry, it cut off my prescription at the bottom, so it's a bit makeshift there. So that's your PRN prescription, which you'd prescribe in the PRN section. And then for your regular prescriptions, oh, if I can get this to work. So your new prescription is your 90 milligrams, sorry, of MST continuous, and you prescribe it like that. So the brand name, MST continuous or continuous, and then in brackets, morphine sulfate modified release. And if you're unsure of if it's modified release, standard release, or whatever, go to morphine in the BNF, scroll down to medicinal forms. It's right at the bottom. So scroll down to medicinal forms, find the medication you want. So morphine sulfate tablets, continuous, and it'll tell you that it's morphine sulfate modified release. Sorry, I know it's past, sorry. Not too much longer. So you put that in there. You've got your dose, your route, which is oral, and your signature. For your fentanyl patch, this is how you prescribe it. So fentanyl, 75 micrograms an hour patch. and it's transdermal, and the dose is 1 patch. But the important thing to note here is it's given every 72 hours. So you would give it at 8 o'clock in the morning, for example, and put 2 crosses after the box. So you're giving a dose, and then you're not giving a dose for 2 days, another dose, not for 2 days, another dose, not for 2 days, etc. So that's how you prescribe your fentanyl patch. And for those guys who need to leave, feel free to leave. You'll get a copy of these slides, so you'll see I've done prescriptions for everything, so that's all there for you. Okay, let's move on. Sorry, someone was knocking at my door there, and I was like, a quick word on statins. Statins always come up somewhere in OSCE, like they just love statins. Sorry, there's a question. Just confused, if you worked out the daily dose of the conversion to morphine, how come fentanyl is prescribed every 72 hours? Because it's a patch, it's like a modified release preparation, so it lasts 72 hours. It's just the way that it's released, because it's 75 micrograms per hour. So it's not like you're just given 75 micrograms for 1 day, if that makes sense. It's 75 micrograms per hour for 72 hours. Yeah, okay, great. So statins, so if you have an interaction with a statin, so clarithromycin increases the amount of statin, you're more likely to have side effects such as myopathy, rhabdomyolysis, deranged LFTs, and interstitial lung disease. You also, you need to be aware of that. You can hold statins. If you hold a statin for a week while someone's on clarithromycin, they're not suddenly going to have a heart attack because their cholesterol shoots up. It is fine to hold the statin. I've put some stuff about monitoring in there. You don't really need to know it for the prescribing station. It's more for like if you're asked to explain statins and stuff. So I've put that in there. And if someone's of childbearing age, you must prescribe contraception because it's teratogenic, and it needs to be for 3 months after cessation of treatment as well. So I've written a list of the inducers and the inhibitors there for you. I'm sure you all know them, sickfaces.com and crap GPs. You don't need to know all of them. The key ones are like your acute and chronic alcohol, your antifungals, so your ketoconazole, fluconazole, and your antibiotics, and then omeprazole. They're the main ones you need to remember, but it's just a handy mnemonic, isn't it? Tips, so you've probably heard of DAM. That's a good one if you've got someone, if you're prescribing in renal impairment. So you want to stop or hold diuretics, ACE inhibitors, ARBs, and some antibiotics such as gentamicin. You want to hold metformin. You won't stop metformin, but you will hold it. And some diabetic nurses may start the patient on that rapid instead, so they'd give them insulin if it's required, and then NSAIDs as well. So they're things that you would just stop or hold. And it's really up to you. If you've got a really cracking AKI, just stop the medications. Otherwise, you can just hold them for a few days. Again, if you're prescribing clarithromycin for CAP, watch out for warfarin, statins. You can hold the statin, but the BNF says you can continue warfarin, but you must monitor the INR and adjust the warfarin as appropriate. You know, if it goes up, hold it. If it goes down, increase it, whatever. I find it's just easier to prescribe an alternative antibiotic. So in the exam, you'll be given the trust guidelines and the BNF. Well, you might be. If they give you the trust guidelines, use that for the antibiotics. If they don't, just use the BNF. That's fine. And then for drug calculations, the only thing you need to know is what you want over what you've got times by the volume it's in. Even then, I've never had to do a drug calculation in a prescribing station. It's always been in like an injection station. So you're asked to give an injection of, I don't know, IM something or other, and you have to work out how much to give from the vial that you've got, essentially how many mils to draw up or whatever. So that's the only time that you'd be asked that kind of thing. Okay, so finally at the end, sorry I overran a little bit there, but if anyone has any questions or wants to cover any specific scenarios, I'm more than happy to chat through anything now, really. How do you work out the dose for the fentanyl patch? So you need to work out the total amount of morphine that that patient's having in a day. So if they're having 120 milligrams of tablets and 60 milligrams of Oromorph, that's 180 milligrams. Then you would navigate to the BNF, go to medicines guidance, and then go to prescribing in palliative care. Scroll down, it's near like towards the bottom, and you'll see 72-hour fentanyl patch conversion. And it'll have like lists of morphine doses and then the patch that it converts to. So 180 milligrams of morphine is equivalent to the 75 patch. So you just prescribe the 75. If it was 90 milligrams, you prescribe the 50 patch or whatever. I'm just guessing for that. Don't take me on that one. But yeah, that's how you would work it out. Honestly, the best thing you can do to prepare for these exams and your PSA is just become familiar with treatment summaries on the BNF. Hang on, can we go over how you would work out how to add split potassium chloride as a drug additives in fluids? Do you give maintenance fluids over 8 or 12 hours for maintenance routinely? You just put brackets around the therapeutic range and ignore the brackets. Well, prescription, do you write morphine prescription? Okay, so I'll just go from the top. So add and split potassium chloride as a drug additive. It doesn't matter when you give it, like in the morning bag or the evening bag, whatever, as long as the total dose equals the amount that they require. So for a 67 or let's go 78 kilogram person, you round down, so you'd need 70 millimoles of potassium. So if you're doing 12-hour bags or 8-hour bags, whatever, you don't have to give, they don't always have to have fluids up, but you do need to give that 70 millimoles of potassium. So you can give 40 millimoles in one bag and 30 in the other, or 40 millimoles, 20, and then a 10 if you're doing 3. It's really up to you. It doesn't make a great bit of difference if you're slightly over or slightly under, as long as it's not for like prolonged periods of time. So that's how, and at the end of the day, as long as your prescription's right, you're not the one that is actually adding the drug, the nurses will do that. Yeah, so that's how you split them. Do you give maintenance fluid over 8 or 12 hours? Usually, yeah, usually 8 or 12. It's really up to you. If they're, I have seen 4-hour bags given before, but I'm not sure why necessarily you'd want to do that. Maybe if they needed more replacement, you would give a shorter bag, if that made sense. What section do you write the morphine prescription in? So, right, this depends on whether they're an inpatient or if they're going home with their morphine. If they're going home with their morphine, you would need to do a controlled drug prescription, which is separate. And in your controlled drug prescription, it's a bit like your FB10. You'll not be tested on it, but it's the same. You'd write the prescription out the same, except you have to prescribe a number of tablets for them to go home with. So if they needed a month's supply twice a day, that's 56 tablets. You'd have to write 56 in numbers, and then in brackets, you'd have to write 56 in letters. That's the only legal thing where you have to write the number and the words out in full, is the amount of drug that you're giving, like the number of tablets, the number of vials, you know, that kind of thing. What are the recommended time for giving regular drugs? So usually you don't want it like in the middle of the night when patients are sleeping and stuff like that. So it just depends when the drug rounds off that hospital. So during the waking hours, any time is game. You know, you can prescribe whenever you want. But usually you should try to keep between 8 and 8 p.m. if possible, unless it's like an IV drug where they can just like screw it on and it's not waking the patient up or anything. Do Do you know if they have asked about atypical organism pneumonia? If they do, will they give any clues in the history at all? No, it's always been barn door classic, like lobar pneumonia, and they give you a sputum sample saying it's grown strep pneumoniae with these sensitivities or resistances, or they just will tell you it, you know, they'll give you an x-ray, it's a lobar pneumonia, and then just prescribe whatever you need. It's never as complicated as that. It's always dead simple because they want you to do the prescribing. They don't want you necessarily to do the differential diagnosis. That's what your examination stations and your histories are for. If someone had an AKI, would you cross the full drug off? Would you cross the boxes out for 3 days? It depends. What would I do? I think I personally would cross the drug off and write held because stop because due to AKI, and then you just have to write up another Cardex when their AKI resolves, if they still have paper prescriptions. It's so much easier with electronic prescribing because it just gets crossed off anyway, and you can just go in and write the prescription again. It's fine. You don't need to find a new Cardex or anything like that. But for your exam, just cross it out. Just cross it out. Just stop the drug. That's fine. Oh, it's all right. I wanted to ask if you think it'd be like we need to prescribe sliding scale insulin. No, I've never seen that in any like OSCE stations. To be fair, I don't even like it didn't come up in the PSA either. I think that's a bit complicated to prescribe. Yeah, thank goodness. Yeah, yeah, no. The only insulin doses that you need to know are for DKA. So you need to know that it's a fixed rate insulin infusion of 0.1 units per kilogram per hour, I think, yeah. So that's the only insulin dose that you need to know. The only doses that you need to know are your emergency drugs. But you're unlikely to be asked to prescribe those in your OSCE. Your emergencies should come up. So it's 0.1 units per kilogram per hour. So for like a 70 kilogram person, it's like 7 units an hour. In the 5th year OSCE this year, you had a cross off of the last dose of the antibiotics, but I wasn't sure why. Did you? I mean, I got 97% in that one and I didn't. So what did I do? What was the situation? Oh, I think what you might mean is that they had already had a dose of an alternative antibiotic that day, so you had to start the prescription, the dose later. So if they've had an 8 AM dose of a drug and you're not prescribing a stat dose, you know, you're not going to give another 8 AM prescription the same day for an alternative antibiotic because time's moved on, you know, so just give it any time. But that might mean if you're doing a 3-day course, you're not going to give the next one until, you know, it might like, and if it's twice daily dosing, there'll be a dose that hangs over at the end. But yeah, I didn't cross off any last dose of the original antibiotic. But I could be wrong. I don't know. Okay, great, fine. Does anyone have any other questions? Sorry, that was very like whirlwind tour. There was so much to like get in. But yeah, I'm happy to answer any questions. I should have put my email up there, but I'll pop it in the chat if you wanna email me any queries. My university one's probably gonna die soon, so just yeah, send me an email if you don't want to now. Because as a 5th year finished, I've got nothing to do. Rapidly go over drug calculations. So I can. Basically with your drug calculations, let me see if I can write on here. So like what kind of examples? So I don't know. Maybe you want to give, oh, okay, fine. So say if like an antibiotic dose is 7 milligrams per kilogram and somebody weighs, I don't know, 100 kilograms, big person. Well, you'd use ideal body weight for this calculation, but purely just for the sake of it, you'd need 700 milligrams. But if that only came in vials of 500 milligram in 5 milliliters, and then you'd be asked to like work out how many milliliters of drug do you need to give. So you do what you want is 700 over 500 times by the volume it's in, which is 5. So if I get my trusty phone calculator, because I'm not that good at mental maths, so that equals 7 mils. Does that make sense? Yeah, that is basically the hardest. Well, they might be funny with like 7 milligrams per kilograms per like hour or per day, and they need a 3-day course, so it just adds another like step into the calculation. But yeah, that's about it really. Does anyone have anything else quickly that they wanted to? No, we all good? Fab. I'll stop sharing my screen. I don't know how I'm doing this.